Let's discuss about Periodontal Pocket. I'm Dr. Neha Karu, head of the Department of Periodontics. We'll cover the entire topic under the following heading: Introduction, Classification of Periodontal Pocket, Pathogenesis, Clinical Features, Histopathology, Bacterial Invasion, Microtopography, Pockets as Healing Lesion Content, Disease Activity, etc. Coming to the definition, periodontal pocket is defined as a pathologically deepened gingival sulcus. So it is basically a fissure which is present between the tooth and the clavicular epithelium. It is limited at the apex by the junctional epithelium. It is an abnormal apical extension. So this is the junctional epithelium. This is basically a fissure. This is the clavicular epithelium and this is the tooth. So it is the apical migration. This is the apical migration or extension of the gingival crevice, which is caused by this migration of junctional epithelium along the root surface, as the periodontal ligaments which are present here are detached by the disease process. So this definition is as per the glossary of periodontal terms. This deepening of gingival sulcus may occur either by coronal movement of the gingival margin, by apical displacement of the gingival attachment, or combination of both the coronal movement of margin and apical displacement of the gingival margin. Coming to classification of periodontal pocket. So pockets are classified as gingival pocket and periodontal pocket. Periodontal pockets are further classified as suprabony pocket and infrabony pocket. Suprabony pockets are also known as pseudo pockets or relative pockets or false pocket. Periodontal pocket, on the other hand, are known as absolute or true pocket. This is seen in gingivitis. Gingival pocket is seen in gingivitis, and periodontal pocket is seen in periodontitis. The gingival pocket is basically formed by the enlargement of the gingiva without extension of underlying periodontal tissues, without destruction of underlying periodontal tissues. And periodontal pocket occurs with the destruction of the supporting periodontal tissues and loosening and exfoliation of the teeth. In gingival pocket, the sulcus is deepened because of the increasing bulk of gingiva. Periodontal pocket is further classified as suprabony pocket and infrabony pocket. The suprabony pocket is which lies above the margin of the alveolar bone, and infrabony pocket, which involves the destruction of the alveolar bone, and the apical margin of the pocket lies below the crest of the alveolar bone. Suprabony pocket is also known as supracrestal or supraalveolar pocket. Here, the bottom of the pocket is coronal to the underlying alveolar bone, and its lateral wall consists of soft tissue alone. On the other hand, infrabony pockets are also known as subcrestal or intraalveolar pocket. Here, bottom of the pocket is apical to the crest of the alveolar bone, and lateral wall consists of soft tissue as well as bone. In suprabony pocket, the pattern of destruction is horizontal, and infrabony pocket it is vertical. In suprabony pocket, interproximally, transseptal fibers are arranged horizontally between the base of the pocket and the alveolar bone, whereas in infrabony pocket, these fibers are arranged oblique, which extend from the cementum beneath the base of the pocket, along the bone, and over the crest of the cementum and bone. On the facial and lingual surfaces, periodontal ligament fibers follow the horizontal oblique course, and on facial and lingual surfaces, the periodontal ligament fibers follow the angular pattern. Pocket is also classified as simple pocket, in which involves only one surface, compound pocket, which involves more than one surface, or complex or spiral pocket, which originate on one surface of the tooth. It twists around the tooth, involving one or more surfaces, and opens into the oral cavity on the surface of the origin. So this is known as complex or the spiral pocket. The formation of the pocket takes place by the initiating factor being bacterial plaque, which is present on the tooth surface, which leads to inflammation of the marginal gingiva. So because of this inflamed marginal gingiva, gingival sulcus deepens, which is we call as gingival pocket, in which there is enlargement of the gingiva. Now, anaerobic microorganisms tend to colonize the subgingival plaque, mostly spirochetes and motile rods, due to an anaerobic environment created in the pocket. Now, large number of PMN, polymorphonuclear leukocytes, and macrophages migrate to the gingival tissue in response to this bacterial challenge. What is the mechanism of collagen loss? One is by the presence of lysosomal enzymes like collagenase, which is released by PMN leukocytes, which leads to destruction of collagen fibers in gingival connective tissue. And the other is that fibroblasts directly phagocytose collagen fibers by extending cytoplasmic process to the ligament system interface. Both these processes leads to the destruction of the collagen fibers, which are present apical to the junctional epithelium, leading to the movement of the junctional epithelium in an apical direction until they come in contact with the healthy collagen fibers. Once this junctional epithelium get detached from the tooth surface, polymorphonuclear leukocyte cells migrate towards the coronal portion of junctional epithelium. So when this volume of VMN increases or crosses around 60%, the epithelial cells separate from the tooth surface, leading to pocket formation. Plaque removal is further difficult or impossible from the deep pockets, leading to favorable growth of pathogenic microorganism in this protected environment, further attachment loss, and further leading to horizontal bone loss. Coming to clinical features and causes of the periodontal pocket. So the most common appearance of periodontal pocket is the color changes from changes to bluish red, especially on the gingival side wall of the pocket. The gingival become flaccid. It has a smooth or a shiny surface and it causes pitting impression. The reason for this is the discoloration is mainly because of the circulatory stagnation. Flaccidity is due to destruction of the gingival fibers. Smooth shiny surface is because atrophy of the epithelium, and pitting on pressure is because of edema and degeneration. Gingival wall may also appear pink or firm when fibrotic changes predominate over exudation and degeneration. Bleeding on probing may be due to increased vascularity, thinning and degeneration of the epithelium, and proximity of the engorged vessels to the inner surface. Probing is generally painful, which is because of the ulceration of the inner aspect of the pocket wall. Pus may be present, which is because of the suppurative or inflammatory components. Other clinical features include thickened marginal gingiva, loss of stippling, tooth mobility, and diastema formation. Histopathology, soft tissue wall or lateral wall of the pocket. In this, the epithelium shows two types of changes, proliferative changes and degenerative changes. So epithelial cells proliferate into the underlying connective tissue, forming deep retipex. Microulcerations develop on the soft tissue wall. This pocket epithelium is infiltrated by polymorphonuclear leukocytes and edematous fluid form inflamed connective tissue. Bacterial invasion in intercellular space of epithelium, example gram-negative organism, P. gingivalis, Prevotella intermedia, Actinobacillus actinomycetum comitans is seen. Connective tissue become edematous. It becomes densely infiltrated with plasma cells. More than 80% of it constitutes of lymphocytes and PMN nucleocytes. Vascularity increases. Blood vessels become dilated and engorged. Area of necrosis and degeneration are seen. Separation is very commonly seen. The bacteria which are commonly seen in pocket epithelium are filaments, rod, and cocoid organisms with predominant gram-negative cell wall. P. gingivalis, Prevotella intermedia, Actinobacillus actinomycetum comitans is also found in the tissues. So bacteria may invade deep into the basement membrane to the connective tissue. These are tissue invasive bacteria. Scanning electron microscopy has described several areas in the soft tissue wall of periodontal pocket. These areas are irregularly oval or elongated and adjacent to one another, and they measure about 50 to 200 nanomicrometer. These findings suggested that the pocket wall is constantly changing as a result of interaction between the host and the bacteria. Coming to electron microscopic examination of the lateral wall, the 7 different type of disease activity zones have been identified. First is area of relative quiescence, in which there is a region with minor depressions and elevations, areas of bacterial accumulation, which accumulate in deep epithelial surfaces in these depressions, areas of emergence of leukocytes, where leukocytes are emerging through the intercellular spaces, areas of leukocyte bacterial interaction, areas of intense epithelial desquamation, areas of ulceration, and areas of hemorrhage. Periodontal pocket is healing lesion. So periodontal pockets are inflammatory lesions and constantly undergoing repair. Complete healing does not occur because of persistence of bacterial attack, which continue to stimulate an inflammatory response causing degeneration of new tissues, which is seen in edematous pocket wall. When the inflammatory component predominate, the lateral wall appears soft, edematous, friable, with smooth, shiny surface and bluish-red discoloration, which is fibrotic pocket wall. When reparative changes predominate, the gingiva appears fibrotic and pink. In some cases, outer surface of soft tissue wall is fibrotic, while inner surface of soft tissue wall is inflamed and ulcerated. Content of pocket: it contains microorganisms, bacterial products, GCF, remnants of food, salivary mucin, desquamated epithelial cells, leukocytes, and purulent exudate may be present. Coming to root surface wall of the pocket, root surface forms the medial wall of the pocket. So root surface that get exposed to the oral environment as a result of periodontal attachment loss undergoes following changes: structural changes, chemical changes, and cytotonic changes. So this cementum, which is exposed to the oral environment, the mineral which are present in the saliva, it tends to get deposited on the cementum surface, leading to areas of hypermineralization. The root surface become exposed to oral fluid and bacterial plaque, leading to proteolysis of embedded remnant of sharp piece fiber, leading to areas of demineralization, leading to formation of root caries, which are usually yellowish or light brown patch. They are soft and lethargic on probing, and patient feels severe sensitivity to thermal changes and sweets. Pulp exposure may occur in severe form. The main microorganism which is found in root surface caries is Actinomyces viscosus. Chemical changes are seen which leads to more absorption of calcium, phosphorus, magnesium, and fluoride, leading to increased mineral component, and certain areas of the root surface become resistant to dental caries. Cytotoxic changes includes uh, invasion of bacteria and their endotoxins in the cementum. These different zones are found at the bottom of the pocket: calculus, attached plaque, unattached plaque, junctional epithelium, partially lysed fibers, and intact connective tissue fibers. Periodontal disease activity is considered as the activity which happens, and according to this also pockets are classified as active and inactive pockets. So these pockets, they go through periods of exacerbation and quiescence resulting from episodic bursts of activity followed by periods of remission. So periods of quiescence are characterized by a reduced inflammatory response and a little or no bone loss and connective tissue attachment loss. Unattached plaque with gram-negative, motile, anaerobic bacteria buildup starts period of exacerbation in which pocket deepening occurs with bone and connective tissue loss. This period will last for days to weeks and eventually followed by period of remission in which gram-positive bacteria proliferate and a more stable condition is established. So these period of inactivity and there are periods of activity. In periods of activity, there is clinically bleeding, spontaneously organ probing, there is greater amount of gingival exudate. Historically, epithelium is thin, ulcerated, and infiltrate predominantly with plasma cells, polymorphonuclear leukocytes, or both. Site specificity: periodontal destruction does not occur in all parts of the mouth at the same time, but rather on a few teeth at a time, or even only at some aspects of some teeth at any given point of time. This is referred to as site specificity of periodontal disease. Therefore, the severity of periodontitis increases with the development of new disease site and increased breakdown of existing site. Coming to periodontal attachment loss and bone loss compared to pocket depth. So pocket formation causes loss of attachment of gingiva and denudation of the root surface. The severity of attachment loss is generally but not always correlated with the depth of the pocket. So pocket of the same depth may be associated with different degree of attachment loss. Like in first diagram, the pocket depth is 5 mm, but the attachment loss is different in other three cases. Or the different pocket depth but same amount of clinical attachment loss, like in second photograph or second diagram, there is almost an attachment loss of 5 to 6 mm, but pocket depth varies in A, B, and C cases. Normally, the distance between the apical end of the junctional epithelium and the alveolar bone is relatively constant. Now, how do we detect pocket? So, the most accurate method of detecting a pocket is careful exploration with a periodontal probe. Radiographs are not helpful in detecting a periodontal pocket because pocket is a soft tissue change. Also, radiograph has certain disadvantages, like it does not indicate areas of bone loss where pocket may be suspected, as they do not show the presence of pocket depth. Also, we cannot check before and after pocket elimination unless bone has been modified. Sometimes gutta percha point or calibrated silver points can be used with radiograph to assist in determining the level of attachment of periodontal pocket. So basically, there are two different pocket depth, a biologic or histologic depth and a clinical or probing depth. So biologic or histologic depth is the distance between gingival margin and base of the pocket, and clinical or probing depth is the distance to which a probe penetrates into the pocket. The standardized force used for penetration of a probe is 25 pounds or 25 grams or 0.75 Newton. Coming to the depth to which a probe is penetrated, it depends on the size of the probe, force of the probe, direction of penetration, resistance of tissues, and convexity of the crown. The pocket is usually measured at six surfaces, and this is the occlusal surface of a tooth, which is divided into six surfaces: distofacial, facial, mesofacial, distolingual, lingual, and mesolingual. So a probe is inserted parallel to the vertical axis of the tooth and walked circumferentially around each tooth to detect the area of the deepest penetration. If we encounter a crater or a crater-like defect, the probe should be inserted obliquely from both facial and lingual surfaces so as to explore the deepest point of the pocket located beneath the contact point. In multi-rooted tooth, the possibility of furcation environment is checked with a special type of specially designed probe, which is known as neighbor's probe. Coming to the difference between the pocket depth and level of attachment loss. So a pocket depth is the distance between the gingival margin and the base of the junctional epithelium or base of the pocket. And level of attachment is the distance between the base of the pocket and a fixed reference point on the tooth surface, such as cemento-enamel junction. This is cemento-enamel junction, not CET, CAJ. So level of attachment, when we are measuring that, so it is located on the anatomic crown. When the gingival margin is located on the anatomic crown, the level of attachment is determined by subtracting from the depth of the pocket the distance from the gingival margin to CAJ. If both are same, the loss of attachment is 0. When the gingival margin coincide with the CAJ, the loss of attachment equals the pocket depth. And when the gingival margin is located apical to the CAJ, the loss of attachment is greater than the pocket depth, and therefore the distance between the CAJ and the gingival margin should be added to the pocket depth. Bleeding on probing, if gingiva is inflamed and the pocket epithelium is atrophic or ulcerated, bleeding is encountered. To test for bleeding after probing, the probe is carefully introduced to the bottom of the pocket and gently moved laterally along the pocket wall. Bleeding may either appear immediately or after removal of the probe or may be delayed for few seconds. So depending on the severity of inflammation, bleeding can vary from a tenacious red line along the gingival sulcus to profuse bleeding. While probing around the implant, a plastic probe can be used instead of steel probes to avoid scratching the surface of the implants. These are the references. The treatment of the pocket will be covered in next section. Thank you.